we will start. It's 9 o'clock. Well, good morning, everyone. It's a real pleasure to welcome you all of you today in this structural master class. Today, we'll be focused on TAVR in bicuspid anatomy. As we know, setting that continues to be challenging even in expert hands, and this is due to its heterogeneity and procedural complex. Today, we are very honored to have with us Professor Dr. Ole de Backer, one of the foremost international experts in structural interventions. Professor de Backer is a cardiology professor at the University of Copenhagen and served as a senior consultant in Rick Hospital in Denmark. And as well is a very, very known groundbreaking work in transcatheter therapies and his contribution in this field as well. And imaging and complex anatomy interventions have been shaping the practice nowadays. Ole, the stage is yours.
Yes, thank you, Jose, for this introduction. I hope everybody there locally can understand me loud and clear. I will share well, maybe before I share my slides, I can introduce myself in 30 seconds. I'm indeed Ole de Backer. I'm working since 15 years in Copenhagen in the University Hospital doing interventions. And the last 7 years of my life, I actually only dedicate to structural heart intervention. So I do Monday to Friday, I only do structural procedures. That's of course 65% of my time is TAVI. So that's the big bulk, big volume is 600 TAVI cases a year I do. And then I do also left atrial appendage. I do mitral tricuspid cases, of course, around 150, and I do like left atrial appendage occlusions 150 and around also 150 PFO closures. And I do some TAVRs as well, the thoracic endovascular aortic repair grafts, the big aortic grafts. So in that sense, I do my whole occupation of structural. So the topic of today is bicuspid aortic stenosis and the treatment with TAVR. Well, it is more challenging maybe still indeed than tricuspid, but it's a common thing to do for me these days. I mean, 1 out of 5 cases, so 20% of my entire TAVR volume last year that I did was bicuspid. So I did more than 100 bicuspid cases treated with TAVR. So this is not a rare animal or a rare case. No, this is almost a daily, not daily, but second daily, almost every second day, I for sure have a bicuspid case to treat. And there are, of course, some particularities of interesting things to know about. This presentation, hopefully it's around 45-50 minutes. It's both a little bit of background theory, but also some practical tips and tricks I wanted to, or advice I wanted to put in there. So first, as a general introduction. So bicuspid aortic stenosis, of course, there are some possible anatomical differences between bicuspid and aortic stenosis when you have to treat this with TAVI. First of all, very often these cases, at least in Europe or Northern America, they often also have larger annuli dimensions. Not always. I also have small bicuspids, but still, these patients also sometimes have aortopathy, a dilated aorta, and then that also gives a dilated or larger risk of large aortic annulus dimensions. Also, sometimes, especially in the very young patients, the patients below 75 years or 70 years of age, they have very, very severely calcified, excessively calcified leaflets, much more than on tricuspid. There is, of course, sometimes the presence of the calcified raphe in the type 1 bicuspids. As I told you, sometimes you have to deal with extra large aortic roots, the coronary ostia, which are sometimes more eccentric. Typically, it's not a concern. The coronaries are less a concern in bicuspid than in tricuspid because typically the sinuses are relatively large. So this is typically not a concern for me. You have these enlarged dilated ascending aorta, sometimes a coarctatio of the aorta. So you have to look always very well on your CT scan, also to the aortic arch, if there is no acutely angulated aortic arch, because if that's the case, there's not a problem. You can go for a balloon expandable steerable system, or you can take a long delivery sheet where you can deliver Evolut or any other self-expanding device. Then I take a 65 centimeter long dry seal sheet, which goes over the complex arch, and then I deliver my self-expanding devices through there. So that's also issue. Anyway, TAVI and bicuspid aortic stenosis is still in the literature and also in clinical practice associated with an increased risk of paravalvular leak for sure, especially if you're treating these excessively calcified bicuspids type 1 with very long calcified traphes. There is a higher risk of moderate paravalvular leak, around 5 to 8% versus only 2-3% in a normal TAVI population. There is also a higher risk of permanent pacemaker. That's because the membranous septum is actually shorter, typically in a bicuspid patient than in a tricuspid patient. There is more risk of valve malpositioning. There is more stroke risk. There is more risk of annulus rupture for sure if you use a balloon expandable device because the sizing is not always easy. And then there is also the issue of stent frame under expansion, non-circularity. And we also don't know a lot about the valve durability, to be honest, in bicuspids. So what kind of anatomies or do we see of bicuspids? Typically, this is mostly for Europe. I don't know if it's also valid for Latin America or so, but I think it is. The majority of cases we see are type 1 bicuspid cases with a raphe. Whether it's calcified or not, most of the time it's a calcified raphe. Here on this picture, there is no calcified raphe. Then you have the type 0 bicuspid, 5 to 7% with real 3 real cusps. And then you have the more rare cases. And nowadays it's actually not called bicuspid cases anymore, where you have 2 calcified raphes. We called it in the past bicuspid type 2, but nowadays with the new classification, we have to call it actually unicuspid cases. You see that here. So here you see this is the old classification, type 0, type 1, type 2, depending on the number of raphes or calcified raphes. But the type 2 bicuspid is actually nowadays called unicuspid valves. And this is also, I can tell you, I've treated in my whole life maybe only 5-6 cases with type 2. And these type 2 bicuspids, as we know from the Notion 2 trial, they are extremely high risk for annulus rupture. So if you have a type 2 bicuspid case referred to you to treat with TAVI, you have to really discuss well if this patient is not a surgical candidate, because we know that the annulus rupture risk is much higher in these particular cases. So what is also particular in if we do a CT analysis for bicuspid, this is a little bit more comprehensive CT analysis than a regular tricuspid aortic stenosis case, I would say. We are not only interested in the classical measurements like the aortic annulus, LVOT, sinotubular junction, and the aorta, but we are also more interested in the supraannular anatomy or architecture. Yes, so we're sometimes measuring, or not sometimes, we're always measuring the supraannular leaflet at supraannular level 2 mm, 4 mm, 6 and 8 mm. I measure the intercommissural distance, that's that ICD, the intercommissural distance. I also measure the lira, that's the opening area at the most constrained part where the calcified raphe is. I measure for sure how long the calcified raphe is. So I measure a lot of additional measurements I make a little bit supraannular, just above the annulus, because that's the part where our TAVI valve, TAVI prosthesis is going to anchor and going to seal. Yes, you do not need the annulus to anchor and seal in a bicuspid case. With your TAVI prosthesis, you anchor and you seal clearly in your calcified leaflets. And so that's what we do. CT analysis. So we look to the morphology, the location of the cusps, the number of leaflets, commissures. We look to the amount of calcium. We look whether there's a calcified raphe, yes or no. We look to the supraannular orifice or the architecture of the supraannular plane. And then we look also at the coronary ostia. On the other hand, before I continue on this whole chapter on bicuspid, I mean, I have to tell you that there is unfortunately disappointingly little literature or data or evidence of TAVI in bicuspid. This is a summary we made. We looked on what kind of studies with how many patients. There is both retrospective, prospective of TAVI in bicuspid or TAVR in bicuspid. And you see most of the data available, unfortunately, is only retrospective data, most of it. There's very few prospective data, and there's actually no prospective data comparing TAVI with surgery a properly powered, statistically powered study, there is not available. The only study that really compared tricuspid and bicuspid, that compared TAVI with surgery in bicuspid is actually a portion of the Notion 2 trial. But for the rest, it's all retrospective data, and very often it's single arm, or it's even just comparing bicuspid versus tricuspid. So the data we have are cherry-picked data where people or operators selected this case to be treated with TAVI, but there may be many patients are screen failed for TAVI. Even worse than that, we also, even if we look into the literature, there's very often no knowledge about whether it was a type 0 or type 1 or type 2 that was treated in these studies, or more than almost 80% of cases, there is no reporting on which kind of type bicuspid was treated, and we have very little long-term follow-up data on TAVI and bicuspid. So I think we're treating a lot of bicuspid patients already with TAVI, but the evidence or the data available is currently very poor. So what data do we have on TAVI versus surgery in bicuspid? Well, it's, as I told you, almost only from the Notion 2. What was the Notion 2? Very quickly, this was a trial conducted in North Europe in young, low-risk patients. So young, less than 75 years or 75 years or younger, with severe symptomatic aortic stenosis and a low surgical risk. So an STS score of below 4, the average was even 1.1. And these patients were 1-to-1 randomized TAVI versus surgery. We allowed also bicuspid cases in it. It was a relatively small trial with around 400 patients, but still 200 in both arms. The primary endpoint was death, stroke, or re-hospitalization at 1 year, a couple of secondary endpoints. Then here you see the distribution of the age. So the average age was 71 years, a very low STS score. So this study, Notion 2, is a study in truly young patients, average age 70, 71, extremely low risk STS 1. So that means these patients almost did not have any comorbidities. These were really robust patients walking on the street like a robust guy you see walking on the street coming in for a consultation. He has a severe aortic stenosis, and you randomize him to surgery or to TAVI. Then if you see for the primary endpoint in the tricuspid cohort, you see that TAVI and surgery was almost equipoise. They was almost on top of each other. So as expected, now we're going to report in this week in ESC the 3-year follow-up. I can tell you it's equally good for the tricuspid cohort. But you see that early on in the peri-procedure, there for the bicuspid cases, there was clearly more risk with TAVI than with surgery. Yes. And you see here, if you look to death or disabling stroke, there are a couple of more events with TAVI, especially annulus rupture cases. There were 2 annulus ruptures in type 2 bicuspids. That was one issue. There were a couple of strokes as well with the evolute valve, where a lot of valve repositionings were done in some centers. So that's what you see here if we break down on the Notion 2. So we see these are the real events of mortality or stroke that happened in the tricuspid or bicuspid arm. You see in the bicuspid arm, for the surgeons, if you have a young patient, robust, young, low-risk patients for surgery, they do very well. So I'm still not sure that what they're doing in the US, in America, where they're treating young, low-risk patients with bicuspid anatomy systematically with TAVI, I'm not sure if that's the way forward. I think you see that their outcomes with surgery are really, really well. With TAVI, they're also pretty well, but you still see that there are 2 mortalities. That's these annulus ruptures. One was a contained rupture that broke a month and a half after the TAVI, but the patient was found with a complete hemothorax. And then there are a couple of peri-procedural strokes, because I told you, so some valve repositionings. You also have, surprisingly, in the tricuspid arm, in the Notion 2, some late strokes, and these are all have to do with valve under expansion. Both it can be from the accurate valve, also from the sapien, but also from the navitor. These valves were found with valve stent frame under expansion and also leaflet thrombosis, and that's why there was more late stroke in this arm. But here you see the mortalities. That's I show you here. That's these type 2 bicuspid. So these are bicuspid cases with 2 calcified raphes, and you see if you ever see this and you get this patient referred to you, I would say don't treat it with TAVI, or if you treat it with TAVI, be extremely careful with the size of balloons. Go with a self-expanding platform, most likely Evolut, and then go very careful with pre-DIL, post-DIL, but you really risk to kill these patients on your table due to an annulus rupture with balloon expandable for sure. On the other end, if you go here, you see also some strokes, periprocedural strokes in bicuspid cases. These were all related to a lot of valve repositioning. So typically the centers who did this they had chosen an Evolut. They repositioned 5 times, 7 times in the other case, and these cases resulted in some periprocedural stroke. So also if you do a bicuspid case, pre-dilate very well. Try to implant your valve. Even if it's a self-expanding repositionable valve, try to position it from the first time, or try to reposition as little as possible, and then post-dilate in most of your cases. That would be my advice. So as a lessons learned from Bike Notion 2, bicuspid phenotypes do matter, whether it's a type 0 or type 1 or type 2. It's very important that you see and look at the anatomy in detail. If it's a type 2 bicuspid, be careful. Different valve types have different pros and cons. Balloon expandable is maybe the easiest, but has the highest risk of annulus rupture, so be careful with your sizing. If you go for the self-expanding devices, I would not advise self-expanding devices with too little radial force. You need a self-expanding device with high enough radial force, like you have Evolut, like you have VitaFlow. These are very strong valves, but try to keep the repositionings as low as possible, and then also be careful with the sizing. I will tell a couple of more words about sizing in a couple of minutes from now, but very often in bicuspid cases, you sometimes have to downsize, take one size smaller as compared to the annulus sizing, which we typically use for the tricuspid cases. Thermal embolic protection, should we consider that? That's a question. I'm not sure if there's no data showing this. And then repositioning of self-expanding valves is not always a free game, so try to keep it as low as possible, the repositioning. This is some other data still before I show you a couple of more practical tips and tricks on 5-year outcomes from the Evolut low risk in bicuspid. This was presented recently in New York Valves and EuroPCR. So what is this? This is actually also, again, a cherry-picked study population, because this is not a randomized trial. This is just a parallel cohort next to the Evolut low-risk randomized control trial. This is just a bicuspid registry beside this. So it's cherry-picked cases, but anyway, they have now 5-year clinical and hemodynamic follow-up data. Here you see there were quite some patients excluded for anatomical reasons, 46 patients, also LVOT or leaflet calcification, etc. So this is, again, a cherry-picked data set. You see here that 50% was almost treated with the old Evolut R, 50% with the newer Evolut Pro. Nowadays we have the Evolut FX already. But still, also important to know is that the sizing was typically done on the aortic annulus sizing, so not really downsizing on the intercommissural distance, etc. And pre-dilatation was locally performed in 91% of cases, so that's good. I will pre-dilate 100% of my bicuspid cases, to be honest. So here, to show you a little bit an overview of the bicuspid cases in this kind of registry from Evolut low risk, you see, of course, again, these are very much cherry-picked bicuspid cases. If I see these pictures, these are extremely easy bicuspid cases. I mean, the bicuspid cases I treat in my center are typically much harder than these cases. So this shows that this is a very cherry-picked population. Typically, the cases I treat are much more severely calcified, have much stronger calcified raphes. So these are easy bicuspids, but still, it's interesting to look at the 5-year outcomes with these with this. So here you see on the right-hand side, you see the results from the regular Evolut low-risk randomized control trial comparing TAVI with surgery, where TAVI was slightly better than surgery up to 5 years. On the left-hand side, you see the outcomes of mortality and disabling stroke in the bicuspid cohort. You see that this is almost nearly the same or even better in the bicuspid arm. Why is it even better, the mortality or disabling stroke? Because these patients are even younger. They are younger and lower risk. I can show you that here in the previous slide. You see in the bicuspid cohort, patients were typically 74% was below 75 years of age. In the classical randomized trial, it was only 50%. SCS prom surgical risk was 1.4. In the normal population, 2.0. So that's the reason why these outcomes of mortality and stroke are even better in the bicuspid cohort as compared to the tricuspid cohort. Also, other 5-year clinical outcomes are actually pretty well. No shocking other outcomes to notice. The only thing I already mentioned you before, you have a higher pacemaker risk in bicuspid. Here you see 21.8% permanent pacemaker implantation. That's classical, that in bicuspid patients the risk is higher. Although, and here you see that the moderate PVL rate at 5 years is 0%. Again, that confirms that these were cherry-picked cases. What is good, however, on this study is that they have hemodynamic, so valve performance outcomes up to 5 years, and that's reassuring. I mean, you see that even in the bicuspid, on the left-hand side, you see the bicuspid cohort. So this is all about Evolut, but the valve performance of Evolut in low-risk bicuspid cases up to 5 years seems very, very performant, seems very good. And the valve for hemodynamics keeps almost unchanged as compared to immediate post-procedural. Also, the patients, their quality of life is very good. It's 95% of KCCQ summary score. And also you see that the number of patients alive and well with a good high quality of life score of more than 75 is more than 80%. So patients are getting benefit of the therapy. So in summary, from this registry study, so up to 5 years, TAVI with the Evolut valve in the low-risk patients with bicuspid aortic stenosis demonstrated indeed very low and acceptable mortality and disabling stroke rates, low reintervention rates of only 3.7% up to 5 years, and durable valve hemodynamics. However, again, limitations are these were cherry-picked patients, selection bias. This was a non-randomized, just an observational registry study. So, having said that, I think this is a lot of good news about TAVI and bicuspid, but there is also more concerning news about TAVI and bicuspid. And this is one of the studies I want to highlight, which are very important to me. You can see here, this is a cohort from the Cedars-Sinai group from Raj Makar in Los Angeles. What they do, I know this center very well. They're using mostly balloon expandable SAPIEN valves to treat majority of their patients. They also have a big cohort of bicuspid patients where they treated these patients with SAPIEN. What they also have is very often post-TAVI CT scans. So they have more than 229 to be exact, patients with a bicuspid aortic stenosis treated with TAVI with SAPIEN. Yes, if they look on the post-TAVI CT, they see that only half of the cases of the SAPIEN valves are actually well expanded and well circular. So there is no underexpansion and no eccentricity. In 35% of cases, there is a stent frame underexpansion or there is an ellipticity or eccentricity. In 35 patients, which is 15% of cases, you see that there is both underexpansion and ellipticity of the stent frame, of the SAPIEN stent frame. Is this a problem? Well, yes, this is a major problem, as you see. I mean, because you implant these valves in bicuspid, more often more calcified cases, the stent frame underexpansion is really a problem. It is like you have a problem with coronary stent underexpansion. You see that the leaflet thrombosis, this is HALT, hypoattenuating leaflet thrombosis or leaflet thickening. It's baseline 10% in most of our TAVI patients. But you see, if you leave a valve like a SAPIEN valve underexpanded or elliptical in a bicuspid valve, it goes up to 33% and even up to 60-70% of these SAPIEN valves have severe leaflet thrombosis in cases which are both underexpanded and elliptical. So, and this also translates, unfortunately, into clinical outcomes. So more mortality, more clinical strokes. So this is really concerning. This shows that TAVI is good and well in bicuspid, but if we leave our TAVI prosthesis, our stent frames underexpanded, for sure a SAPIEN, it is a problem. You expose your patient for higher stroke risk, higher mortality risk. I did the same exercise in Copenhagen. We have almost 200 Evolut in bicuspid implants with post-TAVI CTs. You see here, there's the analysis. We did also an analysis of the stent frame. You see that here, we saw exactly the same. We saw in 50% of cases a good expansion, good circularity of the valve prosthesis. In 35%, either under-expansion or eccentricity at the inflow of the evolute, and 15% also with under-expansion and ellipticity. Sometimes these valves indeed are looking like this, like you see here from the picture on the CT image for group 3. However, you see here, this is the evolute stent frame here from the inflow to the leaflet level, from node 0 to node 6 for the 3 different groups. You see indeed for group 3 that the stent frame can be extremely underexpanded. And less than 70% of the nominal stent frame diameter, actually the valve is on the inflow with an extreme frame ellipticity of 1.6. But you see, if you work with a valve with a supraannular leaflet position, in fact, you don't really have to care. Because even if the inflow, you have an extremely underexpanded elliptical stent frame, if you look at node 4, 5, 6, there where the leaflets are of this evolute platform, you see that the stent frame is actually 95% expanded and much, much less elliptical. So this is maybe, this also, by the way, translates in great hemodynamics. And you also see that, by the way, the halt rate, the leaflet thrombosis rate, which is for sapien and bicuspids, went up to 30 and 60, 70%. It stays very low around this 10% with evolute in bicuspid. So which valve prosthesis, which valve type you take in bicuspid is very important. So I would probably not go, if I can avoid for a prosthesis with intra-annular leaflet position, I will definitely avoid it. I have a big preference for prosthesis with supraannular leaflet position, where I know I don't have to care about stent under expansion and the inflow. At the leaflet level, my valve will be nicely expanded. So that's one of the big lessons learned from these 2 studies. We also have longer-term follow-up data because that was hardly there. We only have these 5-year follow-up data from that small registry in the evolute low risk, which shows great results, but these are extremely cherry-picked patients, as I told you. This is from almost 1,000 patients, real-world patients, treated with different prosthesis types in bicuspid patients, worldwide cohort. You see, first of all, that we looked for the valve durability in these bicuspids. TAVR and bicuspid, you see that overall the valve durability is pretty good, with a moderate to severe structural valve deterioration of only up to 8%, severe structural valve deterioration even much lower, 3% for TAVR and bicuspid. But there are a few predictive factors for this valve degeneration or structural valve deterioration or bioprosthetic valve dysfunction. You see, especially cases we often downsize our prosthesis, both balloon expandable and or evolute. But by doing so, we actually have a first signal here that by doing systematic downsizing, that the durability of these valves is maybe worse. Yes, you see that the structural valve deterioration rate goes multiplied by 3. The bioprosthetic valve dysfunction also multiplies with a factor of 2 up to 5 years. So that's a little concerning. It seems that if we do systematic downsizing of our TAVR prosthesis, we maybe will have less good durability. So a lot has to be learned there. Also, we see that, for example, balloon expandable, again, have higher BVD rates. That's logical because there's more patient prosthesis mismatch. So also there is an argument to go more for a self-expanding device, especially in small bicuspid annulus cases. And then also there is more BVF, which is bioprosthetic valve failure. That's the kind of a rate of reintervention. We see that there is more reintervention done in the younger patients. That's maybe also because younger patients, you're easier to re-intervene on. You want to go for the perfect result, but also because the initial result is often less good because these younger patients have more excessive calcification, more longer calcified raphe. So you have a higher risk of a not optimal, a suboptimal TAVI result initially in your index TAVI procedure in these much younger, severely calcified cases. So that's what this study showed. It also shows that PPM, it's highly discussed whether patient prosthesis mismatch, does it really care? I mean, according to some companies, it doesn't really matter that much. But if you look to here, these data set from 1,000 TAVI patients in bicuspids, it seems that those patients who had actually patient prosthesis mismatch right after, immediately after the intervention, that these patients have a more than double so high risk of early degeneration at 5 years. You see here moderate SVD, severe SVD rates, our hazard ratio is around 2. So you have a higher risk of structural valve degeneration and also valve reintervention in this population. So again, it is better to avoid patient prosthesis mismatch and not accept this. So then I go now for the last 15 minutes to some practical tips and tricks. First about sizing, because before you go into the procedure, you have your CT of your patient. How do you do your sizing for bicuspid? There are many different methodologies, as you know, but what do I use most or more and more? Well, there are 6 different sizing methodologies. You have the classical annulus sizing, that's not even calculated in, but you size your annulus. But then you have 6 dedicated sizing methodologies for bicuspid anatomy on your CT. First, you can use the intercommissural distance. Yes, many of you know that. That's indeed, you go a plane 2 millimeter, 4 millimeter, 6 millimeter, 8 millimeter above the annulus, and you try to measure really the intercommissural distance from commissure to commissure. And if you see a very small intercommissural distance, then you have as we call it, a tapered configuration. Yeah, then that's an argument to downsize. If you have a tubed or a flared configuration, you should stick with your annular sizing, which is in a certain study from the DHHA here, the BAVAR study. They say 85% annular sizing, 15% only downsizing. Although in reality, I think people sometimes downsize more easily than this. Then you have the LIRA method, that's on the right-hand side, the supraannular tracing. I'm not sure if this is a reliable methodology. It's mostly popular in Italy by some groups, Italian groups who do this. I'm a bit in doubt whether this is really reliable because the tracing is very dependent from operator to operator, I would say. But still, it brings the attention to the fact that you have to look to there where the raphe, the calcified raphe, is the narrowest, where the ostium is the smallest, and that you try to envision what size of valve is sufficient here. And very often it results in a downsizing, to be honest. What I use mostly myself, I use mostly intercommissural distance, but also a lot circle method. I use the circle method more and more, and not only for bicuspid, but also for tricuspid cases. If I have a doubtful cases for sizing, I simulate kind of the valve. What you do is with that circle method is you simulate the valve in the anatomy and you see if you cover all the commissures. So this is of course a great method for balloon expandable. If you go for a 26 sapien, you simulate the circle of 26 and you really try to see, is this large enough if you downsized, or is it not too big? Do you have a lot of oversize, more risk of annulus rupture? So I like to use that circle method really a lot. I also use it for self-expanding platforms, for sure, for Navitor, or even for, you can use it also for Evolute. But if you use it for Evolute, you have to take into account that, of course, if you simulate a 29 Evolute, the inflow is 29, but the waste is 23. So in Trimencio from Pi Medical, you can even simulate exactly a stent frame of an Evolute 29, and then you can scroll through your anatomy to see if you cover all the commissures. That's what I do. If you don't have Trimencio, then you can even put these rings, you can make them systematically smaller. You can start with 29, see if the 29 is large enough to cover the annulus and the LVOT. Then make a circle of 26 and look if that's enough to cover around 4 millimeters in the supraannular plane, around above 4 millimeter above the annulus. If that's the case, probably your 29 is going to be enough and you don't have to go for the 34 Evolute, for example. So that's how you can use the circle method. The Casper algorithm is also an Italian algorithm. It's a little bit a mix of these different methods. It's like you do the annulus sizing, you subtract 1 millimeter from your perimeter-derived mean or area-derived mean annulus diameter. You subtract 1 millimeter. If the leaflet calcification is high, if it's more than 300 cubic millimeter, that's most of the times the case, to be honest, if you have a real, true, severely calcified bicuspid. and you subtract 1 extra millimeter if there is a very long calcified raphe. So that again, I look at as well. I like to see if there is a calcified raphe. If the raphe is long and calcified, it's almost sure I'm gonna downsize one size. If it's not, if there is no long calcified raphe, I typically stay with the normal annulus sizing. And then these are the last two sizing methods. One is by simulation, computational modeling, really like computational modeling from FEOPS or like from Materialize. They can simulate valves, they can predict the risk of leak or the risk of pacemaker. This is not something I do regularly, but you can ask these companies, but you have to typically pay for that. And then if you still doubt about your sizing, in some rare cases I do, even though I have a lot of experience with bicuspids, TAVR bicuspids, I've treated hundreds in my life, but still, if you have still doubt, you can still do, in these cases sometimes, which is useful, a balloon sizing. And then if you, for example, let's say you doubt here between a 26 and a 29 evolute, but with a 22 millimeter balloon, you go up, you inflate, and you give contrasts just above your balloon, and you see there's no leak. Then for sure, with the 26, you're going to have enough. Then you know you should be able to seal in your calcified leaflets and in your calcified supraannular complex. So balloon sizing can still be interesting. I typically don't do this in tricuspid, but in bicuspid, I sometimes consider doing this. Then about the implantation technique, a couple of tips and tricks, also 6 tips and tricks for that. First, to cross the valve, it's important that you understand the anatomy, yes? That you know, okay, this is a type 1 bicuspid, right-left fusion. If there is a right-left fusion, then I also want to work for everything, for crossing the valve, for doing the predilatation, for implanting the valve in the right-left cusp overlap view, because you look into the commissure. You want to work in a commissural view. You want to have a fluoroscopic angle where you look into the commissure. So that means if I have a type 1 right non-fusion, fusion of the right coronary cusp and the non-coronary cusp, I'm going to work my entire procedure almost in the right non-cusp overlap view, which is the LCC isolation view, which is an aleocranial. So depending on your anatomy, I work in very different angles, but you have to understand in which angle, also if it's a type 0, you can perfectly calculate from your CT, which is the fluoroscopic angle. The fluoroscopic angle, is it an ariocaudal or an aleocranial, or what view is it, to look into the commissure? And that's the best angle to cross your valve. So you're not randomly poking to cross your valve. No, you really look into the commissure, and then you can nicely, within less than 15, 20 seconds, you typically cross these valves. I do my predilatation in this same commissural view. I always will predilate. I predilate all my bicuspid valves, whatever valve I use, balloon expandable, self-expanding, whatever I do, I will always, 100% of cases, predilate. There's no compromise. Sometimes if I use self-expanding devices, evolute or even weaker devices, that's rare, but like a Navitor or something, then I will even do double tap predil. I will double tap, I will fracture as much as possible calcium before I go in there with a valve. Then next, what is the implantation height of a TAVI in a bicuspid? Well, it's high. You implant typically higher in a bicuspid patient than in a tricuspid patient. What does it mean for, now this is for SAPIEN, but for SAPIEN it means that I typically go into, most of my cases, 70% of my bicuspid cases are type 1 right-left fusion cases. So then I also implant in the right-left cusp overlap view. Yes, and that's the best view. You implant in the commissural view. Typically what I do is I don't place my marker on the annulus. I go a bit higher. My marker is a few millimeters above the annulus, and I place this small translucent line at the annulus level. And if you inflate your balloon, then you give fast pacing, you inflate, you typically end up at 0 or 1 millimeter. Yes, with your balloon expandable. That's the perfect height for a balloon expandable. Also for an evolute, for example, or Navitor or whatever, or VitaFlow, whatever self-expanding platform you will use to treat bicuspid valves, typically I aim a little bit higher. For evolute, you typically aim for the normal tricuspid cases for 3 millimeters. It's the absolute lowest I can accept in a bicuspid. Typically, I will aim more for 1 to 3 millimeters. Yeah, that's what I typically aim for. I will never release an evolute at 4 or 5 millimeters. If you do that, you really risk that the valve will dive into the LVOT and you're implanting too low, and you can risk a supra skirt leak. Then it's important, if you've done your implant, I will always screen for valve expansion. Yes, that means you should not only look from an aleo, but you should definitely go and look from your commissural view. And in your commissural view, very often it's a right-left cuspovula view again, because it's typically a type 1 right-left fusion case you're treating. Well, you have to look where the valve is underexpanded. If there is underexpansion, I will typically pulse dilate carefully, but I will pulse dilate. And that's also the thing. Majority of my cases, 2/3 of my TAVI cases in bicuspid, I will pulse dilate because I know that many of these valves are just underexpanded. So I try to give them an extra push to circularize. This is even more important. So if you're treating patients with valves, TAVI prostheses with intra-annular leaflet position, just because I told you before that if you leave these valves super underexpanded or super elliptical, you have a high risk of leaflet thrombosis. So then to finalize with the last 5 minutes, a case example. This is a more challenging case. For example, a type 1 right non-fusion. So it's more challenging because the right and the non-commissure is fused. That's typically where our stiff wire sits in the commissure between the right coronary cusp and the non-coronary cusp. So if this is fused, your wire cannot come to sit there. So it goes typically hand in hand with more procedural challenges. So this is a 62-year-old male patient, prior stroke, COPD, a tall male patient, 190 centimeters, almost 80 kilos. Ejection fraction 45%. ECG looks normal. Coronary arteries are fine. Hemoglobin and renal function are good. This is the CT. So there is calcium at the annulus, clearly. It's not a too large, but still it's 80.6 perimeter, so 25.5 millimeter perimeter derived both at the annulus and the LVOT. This is the sinus. Sinuses are typically large in bicuspids, as I told you, as the junction is 27, so all looks great. The intercommissural distance, you see here already, this is the fused right, this is the non-coronary cusp, the right coronary cusp, so these two cusps are fused, which makes it harder. Yes, the easier bicuspids are typically the type 0s and the type 1 with right-left fusion, but the right non-fusion are harder because I told you our wire cannot fall into that standard commissure between the right and the non. We measure here 25.1, 25.7. So probably I'm going to downsize here. If I'm going to go, I'm not going to go for a balloon expandable here. There's too much risk of annulus rupture. There's quite a lot of calcium at the annulus. Perimeter, it would push you to an evolute 29. You're clearly at the upper range of even evolute 29, but looking at this intercommissural distance, a lot of calcium, a long calcified raphe, probably I'm going to go for a 26 evolute. So I'm going to downsize. You see there's a lot of calcium there in that raphe. High volume here of total calcium is more than 2,000 cubic millimeters. That's severely calcified raphe too. So I'm going to downsize to a 26. These are the implant views. So I will work here mostly in an LCC isolation view. That's the right non-cusp overlap view. Here I will look into the commissure. So that's an aleocranial. This is the arch, which looks good. And then the axis looks also fine. So you see here, I will go for an either expandable sheet or an 18 French dry seal sheet. I will go for pre-dilatation for sure with a careful 2021 balloon. And I will go for an Evolute FX plus 26 millimeter. I will not go for 29. I will downsize here. So here, you see, first of all, we have crossed the valve already. We are pacing. We inflate the balloon. There's a big indentation on the balloon, as you see here. We inflate carefully. You see, we don't necessarily go all the way from in the start. We look to what happens on the balloon. We give one inflation. I stopped here. We let the patient recover. Patient is recovered, and I'm gonna go for a repetition. So this is the double tap pre-dilatation to really modify the calcium as good as possible. And that's not rare. I go often double up with a balloon in a very calcified bicuspid just to make sure that I fracture as much as possible of the calcium in these leaflets. Yes. So I think I go speed up here a little bit. Yeah, this is the second inflation. Here I go more full out. There's still a lot of indentation on the balloon, but I went full out. And you see these spacing runs are very short. It's only 3-4 seconds. All these cases we do are done in local anesthesia. We have no anesthesia in the room, so we manage the whole hemodynamics ourselves. So all this is good. The valve, then the balloon will come out. Yes. Then we go to the next. Now the valve is coming there. So this is an Evolut system, Evolut FX. So we start relatively high. Yes, we want to implant high, even with balloon expandable. I told you we aim typically for 0 or 1 millimeter implant depth, because you see all the calcium here that above the annulus that will anchor and seal, give the sealing for your procedure. So we're trying to keep this Evolut relatively high here at around 1 millimeter. This is good. Now we start the pacing. One pacing is 120. We give a little of contrast. We verify that we're right at 0 or 1. This is looking good. Then we will probably go up with the pacing to 140, 160. And in these 4 or 5 seconds, we do then the expansion. So now we go up to 140, 160. We give contrast. If everything looks good, looks great, 1 millimeter. And now we expand. We expand relatively quick. You see, we expand quickly. Now we go down in the pacing again, 100. We can stop the pacing if needed. I think we're relatively nice high implanted, not even ridiculously high. I think we sometimes even implant higher, but you still see there is a little bit of under expansion. The valve is under expanded for sure. That's because of the severe calcium. Here we give, so yeah, you see here we have quite a gap on that left side. So here we have to be careful. If we release the valve here, we have to be 100%. We know for sure we will have to pulse dilate this prosthesis then. So then maybe we don't want to implant too high, because if we go for the pulse dil, we may have a pop-up. So we need a little bit of safety margin. If you know for sure you will have to pulse dil, it may be that you want to reposition maybe 1 millimeter lower, although I think this is kind of acceptable. Yeah, definitely. It looks at 2 millimeter. I think this looks pretty well. It looks pretty well expanded too. This is the angle, the right left cusp overlap, where the valve looks the most under expanded in. So I think I'm gonna proceed here. I think let's see what we do. We go for a small reposition. You see here. Oh no, we go for actually an expansion. We don't go for an reposition. We decided to expand the valve. Typically, we don't give pacing for the expansion, but okay, here we do apparently. We go, especially this last phase of the, if you do self-expanding devices, I would always do this very, very slow, because the faster you do this, the more brisk maneuvers there can happen with the final release of the valve. So we go very slow, very well controlled here. Typically, I do not give pacing, but in this particular case, we gave some pacing. Then the valve is released here. Yes. Then we pull it out. This was now done on a Lundquist wire. I can see that's not standard, but Lundquist wire is not bad for some difficult bicuspid cases. Yeah, here we give already a little bit of contrast to see the height. We are at actually more like standard 3 millimeter. We have an aberrant origin of the coronary, as you see out there. That was an aberrant origin. And then, yeah, you see this is an aberrant origin of the coronary. And I'm sure we kind of pulse dilated this case. Let's see. Yeah, I'm sure. Yeah, we even went with IVUS. You see, you can do this large peripheral IVUS. You see here, we use that more and more. And if we do TAVI and bicuspid cases, we just take the big peripheral IVUS that I also use if I do TAVR. And you can nicely see the expansion of the TAVI prosthesis. Very often you will see that the prosthesis is extremely underexpanded, elliptical. If I see that on my IVUS, I will definitely be pushed to go for a pulse dilatation. So we do some tracing here. We go for the pulse dil. This is here. I will still want to show you the pulse dilatation here. I'm almost done with the presentation. So we give fast pacing. It's of course super important if you do a pulse dilatation for any valve type that you have very good capture before you go up with the balloon. Otherwise you risk, of course, a pop-up. So let's see here, we give very good pacing. The balloon is well positioned, not too low, not too high. We have a great expansion of the prosthesis. That's cool. Here we do a new IVUS. We see then that there is better expansion of the valve. And I'll show you the final result here. Hemodynamics looks really great here. There is no gradient. There is good end diastolic separation between the ventricular and left ventricular and the aortic pressure curve. And then here, this is the contrast injection I want to show you still. This is, remember, very, very calcified case, right non-fusion type 1. And you see this is a perfect result. There is no leak whatsoever, no gradient whatsoever. You see here again that aberrant origin of the right and the left ostium that has the origin in the same cusp, which also sometimes occurs more often in bicuspid cases. So great result. So anyway, I want to conclude with these last two slides again. So just to say, bicuspid cases are different. It is associated with higher risk of leak, of pacemaker, of valve malpositioning, stroke, especially with a lot of repositioning, more annulus rupture, especially with balloon expandable, if you're not careful with your balloon sizes and your sizing of your valve. But still, I think we learned to do really good TAVI and bicuspid with really great outcomes. However, we're still missing a little bit longer term durability data. I think what happens if we do systematic downsizing? Does this affect durability, yes or no? And we need more prospective and especially randomized control data before we can really push TAVI into younger bicuspid patients, I would say. So with that, I want to conclude this presentation and I'm open for any question. I hope I didn't go too much over time, 5 minutes, I think.
Thank you very much for that an amazing talk. I don't know if someone has some questions for Dr. de Backer.
Sí, Pepe, let me make a comment and a question. Hi, Ole, this is Guillermo Torre. Thank you very much for terrific lecture. I think that all our colleagues that are structural interventionists take notice of all the tricks and the pearls that you gave us during the presentation. But I want to ask you maybe a more general question, and I think that the complexity of dealing with a patient with a bicuspid aortic valve and a dilated aortic root, what guidelines do you have, and how do you manage that? We didn't touch into that too much, but what is the cutoff that you have in terms of deciding whether you intervene or you don't intervene because of the potential of progressive dilatation? And maybe in those that are borderline with a dilated aortic root, what is the follow-up needed to assess the aortic, the ascending aorta, and whether or not treating the aortic valve prevents further dilatation of the ascending aorta? So I know it's a slightly different question than what you went into the presentation, but I think it's from a very clinical standpoint, an important decision-making in the whole question of bicuspid aortic valve and percutaneous intervention.
That's a very good question, and I have. We also have data and evidence on this. We published this, so let me first answer you. If we get a referral, a younger patient with bicuspid stenosis, severe aortic stenosis, and some dilated aortic ascending aorta, my first reflex, and that means above 50 millimeters, yes? My first reflex will be, is this not suitable for surgery? Yes, because you have to consider that an aortic root has to be replaced, especially if the patient is younger than 75 years of age. However, very often there are these patients are sometimes older, they are 82, or they're younger, but they have a lot of comorbidities. So it means it is not acceptable for surgery. So if you have made your check, okay, is this suitable for surgery? The surgeon says no, or the patient says no. Then I think it's absolutely acceptable to treat patients with severe bicuspid aortic stenosis with a dilated aorta. I've treated many of these patients, 48, 49, 50, 52, even 55 millimeter aorta. But procedurally, I would advise to take for sure a stiffer wire. Yes, you need definitely a Lunderquist wire. Don't take just a Safari wire, or that's probably too soft because you have a wide aorta. So I would take a wire which gives, or a steerable system like a Sapien, where you can stay out of the outer curvature. And then I know in the follow-up, we have published data on this with patients who we treated with TAVI more than 5 or 8 years ago with a dilated aorta. The good news is 85% of these patients, their aorta stays static, does not further grow. That's great. 85% stays static, or even sometimes gets 1 or 2 millimeters smaller. There is, of course, 15% of patients where there is further expansion of the aorta. We look to more than 200 parameters. What was the associated factor that these patients further dilated, yes or no? The biggest predictive factor was actually where those cases which had very long calcified trapeze, where the prosthesis came to sit a little bit off axis, so not nicely in the axis of the aortic root, but because of this severely calcified trapeze was kind of tilted. We have even images from MR scan that we show that the wall shear stress in these patients is actually less good. So even after TAVI, we see that the highest velocity of the flow going into the aorta still touches on the aorta, doesn't go nicely central in the aorta, but it goes on sideways on the aortic wall, and these aortas keep on growing. So what does it mean? That means if you do a TAVI in a bicuspid patient with a dilated aorta, you have to try to implant your prosthesis as central as possible. Yeah, how do you do that? That's not easy, of course, but that means if you have a very, very long calcified raphe, maybe also consider pushing to surgery again. So a combination of a very severely long calcified raphe and a dilated aorta, I would almost try to push this patient to surgery. If not, I would try to do everything to get a symmetrical valve prosthesis implant, and for sure to pulsatile, because if you pulsatile, typically your expansion gets better, you get better laminar flow in the aorta, and you avoid high vortex flows in the ascending aorta, which gives further aortic dilatation. So that's something we really learned from this study.
Thank you very much. Appreciate it.
Welcome.
Any other question?
Hello, good morning, Dr. de Backer. My name is Anelira. I'm currently a cardiology fellow here at the Hospital Zambrano. And yeah, well, your talk was amazing. Thanks for all the information that you shared with us, all these evidence that you've been gathering, and the experience that you've been harvesting. There's still some gaps in the guidelines, obviously, as like clinical cardiologists, particularly, which is the fellow that us are involved in. The European guideline from 2021, the American guideline from 2020, I believe are lacking still the sufficient evidence, both from randomized control trials and from real world registries. And particularly, like hearing someone like you, who at the beginning of the presentation established that 1 out of 5 patients that you are intervening under TAVR are patients with bicuspid anatomy.
Yeah.
Do you know, or is your center currently involved in developing this registry or some randomized clinical trials that may help change the evidence available and that may reshape and rewrite the guidelines in the future?
Yes. So far there is no prospective data available except for that super small cohort of 100 patients in Notion 2. But I'm collaborating together with there are Stefan Windecker from Bern, Switzerland, is the main initiative taker. He's working on the Navigate trial, which is going to be a trial 1,500 patients, younger bicuspid patients, randomized surgery versus TAVI. We're probably going to kick off the study early next year, 2026. Going to be in Europe and US, as far as I know. I'm also in the committee of this trial, so it's a trial which is going to be very costly. No company is going to sponsor this, so not Medtronic, not Edwards is going to sponsor this. This is purely by foundations, but that study is going to be done. But of course, so the Navigate trial, you will hear from it. But of course, this trial is only going to start enrolling in 2026, probably 2-3 years of patient enrollment. Then we're going to report, probably we're going to report the 1-year data, but it's only powered to report really the 5-year data. So this is still 8 years away, 8 years away before we really have statistically powered data comparing surgery with TAVI. That's a problem.
Thank you, Dr. Backer. Thank you very much.
I make another question?
Yes, please.
Thank you very much for your presentation. I just want to ask, in our daily practice, mainly in Mexico, most TAVI or TAVR procedures are guided with 3D or any other software that they might help to prepare the procedure. And operators tend to rely primarily only on the software outputs. From your perspective, particularly in bicuspid anatomy, what is the added clinical value of performing manual or semi-automatic measurements in imaging reports? Do these measurements still influence the procedural planning or the patient outcomes?
I mean, look, let me say it very clear. Like if you do TAVI, if you are a TAVI operator, you should 100% be, you should do your own CT analysis. point, all the line. I mean, I would never rely on a CT analysis done by a radiographer or by a company. I always do my own CT analysis. If you cannot do this, I think you should not do TAVI. And if you do bicuspid, as I told you, you have to understand very well the anatomy. It's not only annulus or LVOT. I scroll maybe 30, 40 times through these leaflets, up and down, to try to envision really how to understand the pattern of calcification, how calcified is it, how long is the traphy or not. I mean, I try to really imprint this in my brain and I simulate sometimes in Trimencio, you can take these simulated valves in it. I simulate these valves in it. What is the best size? Yes, no, how high should I implant? I mean, this is not a decision on a paper of a report, CT report. I think that's too minimal, really. You should definitely scroll. We call it the scroll technique. You should scroll at least up and down through your leaflets a couple of times to really try to understand. And I think this is not only valid for bicuspid. You should also do this same way of thinking in tricuspid cases. Some operators, I come in many hospitals around in the world. I see many operators that just look 5 seconds to a CT report from the company. They're like, oh yeah, great. This is for an Sapien 26 or an Evolut 29, and they go ahead in the case. I think that's not the way of doing TAVI. You should clearly spend your time on the CT analysis, and in bicuspid, even more so. And you have to understand the whole supraannular complex of calcium.
Thank you very much.
Any other question? Well, I have one last question about it. Ole, about lifetime management, those patients that are not feasible to treat with surgery and they are young, do you have any different or any type of trick during the index procedure for the future procedure?
No, not too particular. I mean, look, not really. I mean, what you try to do is a good thing about if you think about lifetime management for younger patients, the biggest concern is typically, can I revalve this patient then still? And that's typically the coronary problems, yes? Luckily, with bicuspid patients, you have wider sinuses, a bigger aortic root, wider sinuses. So we have also published data on this. Typically, even if you implant Evolut in these patients, you have in the minority of patients a problem of revalving. You will not have sinus sequestration, etc., because those sinuses are wide enough. Of course, it helps if you implant with commissural alignment. So if you take a really younger patient, I would try to advocate to do commissural alignment, or go for, if it's really at risk with a low narrow ST junction, I would go for a balloon expandable, like a lower stent prosthesis intra-leaflet position. So of course you have to look, if you're treating younger patients, not only bicuspid, but also tricuspid patients, I try to think, what if I do now my case, but can I revalve? Can I put a second valve in this case? That's always a second reflex for me if I treat. So I will not go into a case, just implant a valve that I know, like, yeah, if this patient comes back in 5 or 8 or 10 years, I'm going to be lost. I'm not going to have an option. No, that's a bad treatment. I think you should, if you treat younger patients, you should immediately have a plan that you can know you can revalve this patient without a problem. But again, as said, it's typically less of a problem for bicuspid patients thanks to the larger aortic root in the majority of cases. So that's a good thing.
Okay, and well, nowadays the TAVI, the procedure called, in these cases that you have underexpand the first valve for calcium, whatever, do you address it in a balloon expandable or put another self-expandable in those specific cases?
No, then, if you have to revalve the patients, then I would probably go, well, it's rare. Look, in my whole, I've done thousands of TAVI, but only 35 redo TAVIs, so not much. I mean, like, I don't have a lot of redo TAVIs, but what I typically like to do is, if I have to revalve a self-expanding valve, I like to go for a balloon expandable. Because then you can taper your nail skirt height. If I have to revalve a balloon expandable, I like to go with a self-expanding. So I think these two platforms, they are a good marriage together. Like I use one platform to revalve the other and the other way around. So that's what I typically in 90% of my cases try to do.
Okay, thank you very much. Any other final question?
I have one question. question, Dr. De Backer. I'm Mauricio, cardiology fellow, also here at Zambrano. Regarding cerebral protection devices, I know there's still not much evidence that supports their routine use, but in these complex and high-risk anatomy valves, how often are you using these devices? And if you're using them, in which cases do you select for these devices?
Yeah, look, that's a good question. Look, I have had different phases in my life, to be honest. I mean, if you asked me 5 years ago, I was using cerebral protection in 100% of my cases. Then the last 2, 3 years, I had the budget from it's also money, it's economics. I had a budget from my hospital to use it in 1 out of 3 cases. I still have that budget, but to be honest, I use it almost never anymore. I use it very rarely. I use it like today. I used it. I use it mostly. There was a phase where I used it for bicuspids, but I don't really do that anymore. But I use it a lot for cases like today. I did a redo. No, I did not do a redo TAV. I did a TAV and a SAF with unicorn and with some leaflet modification. That's cases where with a lot of manipulation. Yeah, then I'm using cerebral protection. Like if I do leaflet modification or some more complex things like redo TAVR and all that, or chimney stenting, or I mean complexer stuff, I will use it because then my procedure typically gets longer. I'm not doing a lot of manipulations, so then I think thrombotic risk is higher. But just a clean bicuspid, the risk of the stroke with bicuspid is, as you see from Notion 2, it's typically if you start to reposition a lot. And that's what people do, because they go in with the device, especially if it's a self-expanding device, they're a bit more insecure. They're less sure. They think it's too high, too low, too high, too low. And then they reposition 5, 6 times. Finally, they have a great valve implant, but the patient has a stroke. So I think that's also a lesson to be learned. Even if you're working with self-expanding repositionable valves, it does not mean that you have to be less focused and you can reposition unlimited. You have to try to implant these repositionable valves, self-expanding valves, still as you do like a balloon expandable. Try to be super focused with your first expansion and try to go for 80% of your cases that you have a great result with the first expansion. You have to be doing it like that. And if you do it that way, you do not get a penalty of higher stroke. But if you do it a little bit more nonchalance, like you're less focused, because you think, I can reposition anyway. Yeah, then you start to reposition indeed 2, 3, 4, 5 times in all your cases. And then indeed the stroke risk goes up. So that's my take-home message I would like to give you.
Thank you, Doctor.
Well, thank you very much for everyone to see us. And well, really honored taking you here, Ole. See you next time.
No, thank you so much. Many greetings to Mexico there. Bye-bye.
Bye-bye.
Bye. Bye. Thank you.
Bye.